Okay, everyone, settle down, namaste. Welcome. Today, we're not just reading a textbook, no, we're going to become detectives. We're going to investigate a story that's written right inside each and every one of us, in our blood. This is Chapter 14, Part 1. So, Chado, let's get started.
So let me ask you something. I'm sure some of you have felt this. You know that feeling? Completely drained, just weak, tired all the time? Maybe you get breathless just climbing a single flight of stairs to get to this lecture hall, eh? Well, these feelings, they're super common, and they are the classic textbook signs that something is wrong, that our blood isn't quite doing its job.
All right, now for the bookish definition. Anemia. It simply means you have a reduction in your red blood cell mass. But so what? Why is that a problem? Well, it all comes down to this one crucial term, tissue hypoxia. Don't let the words scare you, it's very simple. Hypo means low, and oxia, that's for oxygen. Low oxygen. Your tissues, your organs, your muscles, they are literally starving for oxygen. And without oxygen, come on, you know this, nothing in the body works right. So if you remember one thing today, remember this. Anemia is an oxygen delivery problem. Simple as that.
So, okay, we suspect a problem, but how do we figure out what's really going on? This is where we put on our detective hats. We have to look for clues, and the crime scene is the blood itself. Let's see how a good clinician starts their investigation.
The first step always is a simple blood test. You all know this one, the CBC, or complete blood count. And from that report, we look at a few key numbers. First, hemoglobin, the main protein that actually carries the oxygen. Then there's hematocrit, which is basically the percentage of your blood volume that's made up of red cells. Now, this table you see here, this is like our reference guide, our cheat sheet. We take the patient's numbers and we compare them to these normal ranges. And if that hemoglobin value is low, bang, that's it. We have our first big clue. We know we're dealing with anemia.
But look, just saying anemia isn't enough. That's like a detective saying a crime has been committed. We need more details. So we look closer at the red cells themselves, the so-called red cell indices, and we ask two very simple questions. Question 1, what is their size? We look at the MCV, the mean cell volume. Are the cells too small? We call that microcytic. Are they too big? Macrocytic? Or are they just right? Normocytic. Then question 2, what about their color? For this, we check the MCHC. Are they pale or hypochromic, which means they don't have enough hemoglobin? Or are they a nice, healthy red color? Normochromic. Just these two things, size and color, they help us narrow down the cause of the anemia dramatically. It's fantastic.
Okay, so we have our initial clues from the blood report. Now we can start building a case, looking for the main culprit. And in the world of anemia, things are actually quite logical. There are really only three main ways things can go wrong. Think of them as our three prime suspects.
Suspect number 1, and this is the most obvious one, is blood loss. Just think of your entire circulatory system as a closed plumbing network. What happens if you have a leaking pipe? Well, you lose water. It's the same thing here. If there's a leak somewhere, you're losing red blood cells. This could be something sudden or acute, like a major injury, or it could be a slow, chronic leak, something sneaky like a small ulcer in the gut that bleeds just a tiny bit every day.
All right, suspect number 2 is a production problem. Your bone marrow, think of it as the factory that produces all your red blood cells. It's supposed to be working 24/7, but what if that factory has a problem? What if it slows down, or maybe shuts down production completely? Then you're just not making enough new cells to replace the old ones that are dying off. This can happen for many reasons. Maybe the factory is missing raw materials, like iron or vitamin B12, or maybe there's a more serious problem with the factory machinery itself.
And that brings us to our third and honestly the most dramatic culprit, increased destruction. The medical term for this is hemolysis. This is like internal sabotage. The factory is working just fine, making beautiful red blood cells. But something inside the body is destroying them way too early. A normal red cell should live for about 120 days, right? In hemolysis, they're being killed off way before their time is up.
So, for the rest of our lecture today, let's focus on this third culprit. Let's open up the case files on these hemolytic anemias. And we're going to look at some really fascinating inherited disorders where the red cells are basically born with a fatal flaw, almost like they're programmed to self-destruct. First case file, hereditary spherocytosis. Okay, now think about a normal red blood cell. It has to squeeze through tiny capillaries, some smaller than the cell itself. How does it do that? It's incredibly flexible. And that flexibility comes from a beautiful, intricate internal skeleton, a cytoskeleton made of proteins. Now, in this disease, there's a genetic defect in one of those proteins.
The skeleton is faulty, it's weak.
And just look at the result under the microscope. It's so clear. On the left, you see those beautiful, normal biconcave discs with the pale center, flexible. But on the right, look at that. Those are spherocytes. Because that internal skeleton is broken, the cell loses bits of its membrane and collapses into a small, tight, rigid sphere. Now, what's the problem with that? Well, these rigid balls can't squeeze through the narrow passageways of the spleen. They get stuck. And what happens when they get stuck? The spleen's cleanup crew, the macrophages, just gobble them up. The spleen basically becomes a graveyard for these faulty cells.
Okay, next case. G6PD deficiency. Now, every red blood cell has to deal with stress, specifically something called oxidant stress. Think of it as attacks from damaging molecules. To protect itself, the cell has a bodyguard, an enzyme called G6PD. Its job is to neutralize these attackers. But in G6PD deficiency, the red blood cell is born without its bodyguard. It's completely defenseless.
So look what happens. When these unprotected cells face an oxidant stressor, and this can be triggered by certain drugs, some infections, or famously, even by eating fava beans, the hemoglobin inside gets damaged. It denatures and clumps together, forming these little dark dots inside the cell. You see them in the first picture? We call those Heinz bodies. Now the story doesn't end there. The cell goes to the spleen, and the macrophage says, "Hey, what is this junk inside you?" And it tries to pluck out the Heinz body. It takes a bite, and what you're left with is what you see in the second picture, a bite cell. And of course, this process of taking a bite fatally damages the cell membrane, leading to its destruction.
And finally, our last case for today. And it's a big one you all have definitely heard of, sickle cell disease. This disease is it's a profound example of how one tiny, minuscule mistake in our genetic code, just a single point mutation in the gene for beta globin, can lead to such devastating, widespread consequences. This one tiny change results in an abnormal type of hemoglobin. We call it hemoglobin S, or HbS.
So what's the problem with this HbS? Well, here is the absolute core of the disease. When a red blood cell with HbS goes to the tissues and delivers its oxygen, so in a deoxygenated state, the abnormal hemoglobin molecules start sticking to each other. They link up and form long, rigid polymer fibers inside the cell. This process, polymerization, forces the entire cell to change its shape. It goes from being a flexible disc to this hard, rigid crescent or sickle shape you see here. And obviously, a rigid sickle is not going to flow through a tiny blood vessel like a flexible disc can.
The best way to think about it is like a logjam in a river. Normal disc-shaped cells are like smooth, round logs. They just float on by. But these sickled cells, they're like long, sticky, awkwardly shaped branches. They get tangled up with each other in the small blood vessels, the microvasculature. They create a blockage, a logjam. And this is the disaster. This is what we call a vaso-occlusive crisis. The blood flow is blocked and the tissues downstream are starved of oxygen. This is what causes the excruciating pain and the long-term organ damage seen in sickle cell patients.
Now let's look at one specific organ, the spleen. What does this disease do to the spleen? Well, in the early stages, especially in a child, the spleen is working overtime. It's desperately trying to do its job and filter out all these abnormal sickled cells. As a result, it gets absolutely clogged with them. It becomes severely congested, swollen, and massively enlarged. You can see it's just full of trapped red blood cells.
But this heroic effort can't last forever. Over years and years, the constant logjams and lack of oxygen, it causes repeated damage, tiny little infarcts within the spleen itself. The organ becomes scarred, it undergoes fibrosis, and it progressively shrinks. Until by the time the patient is an adult, the spleen is reduced to nothing more than a tiny scarred, non-functional little nub. It's incredible. We have a name for this: autosplenectomy. Autosplenectomy. The spleen has essentially performed surgery on itself. It has destroyed itself.
So let's bring it all together. What is the big picture here? The most important takeaway is this: anemia is never just feeling tired. It's a signpost. It's a big red flag pointing to some deeper underlying problem. And our job as future clinicians is to be good detectives, to use the clues in the blood to solve these complex medical mysteries. And what we've seen today is just amazing, isn't it? How the tiniest, most microscopic changes, one faulty protein, one missing enzyme, can have such massive, life-altering consequences. And this is why we study pathophysiology. Because understanding the why, the mechanism, is always the first step towards figuring out how to treat it.
So I'll leave you with this thought to carry with you. A single changed protein, a tiny faulty enzyme. How can something so impossibly small have the power to completely redefine a human life? It's just a reminder of the incredible, intricate, and sometimes fragile machinery at work inside all of us. And it really makes you wonder, doesn't it? What other secrets are still waiting to be discovered, written in the story of our blood?
All right, everyone, welcome back. So today we are continuing our discussion on Chapter 14, and we're going to take a really fascinating journey deep inside our own bodies, into the world of our blood. We're going to look at what happens when our red blood cells, the very cells that carry life-giving oxygen, start to go wrong. Just think about it for a second. Our blood is this incredible river, constantly flowing, keeping us alive. But what happens when that system breaks down? What happens when these essential red blood cells, our body's own little oxygen couriers, start to fail? Well, that's what we're going to find out. So, here is our plan for today. We're going to be like medical detectives, okay? We'll investigate a few different case files. First, we'll look at an inherited problem, then an acquired one, and finally, a really interesting case where the body's own immune system gets confused and starts attacking itself. Now, before we jump into the specific cases, let's get on the same page about the common result of all these disorders, anemia. I'm sure you've all heard this term, but what does it actually mean? Well, to put it simply, it's a shortage of healthy red blood cells. And if you don't have enough of them, your body just isn't getting the oxygen it desperately needs to work properly. Okay, let's open our first case file, thalassemia. Now, this is an inherited disorder, meaning it's passed down in the family. A good way to think about it is like a factory that's supposed to build something very important, but it's working off a faulty blueprint. And in this case, that factory is the one that makes our hemoglobin. So what is this hemoglobin? It's the essential protein inside our red blood cells that grabs onto oxygen and carries it around. In thalassemia, the body simply can't produce enough of it. The result? The red blood cells that do get made are smaller than normal, that's what microcytic means, and they're also paler, which is what we call hypochromic. And have a look at this X-ray. It's really quite dramatic, isn't it? This crew-cut look you see on the skull, well, that's the bone marrow inside expanding like crazy. It's working overtime, trying so hard to pump out more red blood cells to make up for the shortage. It's a powerful visual of the body's struggle to compensate. But here's where the problem gets even worse. It's not just that the factory is producing less hemoglobin. The leftover parts, these unpaired protein chains, they don't just go away. They actually build up and become toxic. They start damaging the young red blood cells even before they're fully formed. So it's a double whammy, really. The production is low, and what is produced is getting damaged by the waste material. And as you can see from this table, thalassemia is not just one single disease. It's a whole spectrum. At one end, you have beta thalassemia major, which is a very severe condition needing lifelong blood transfusions. And at the other end, you have thalassemia minor, which can be so mild that a person might go their whole life without even knowing they have it. Right, let's move on to our second case file. If thalassemia was a problem of production, then this next one, paroxysmal nocturnal hemoglobinuria, or PNH for short, is a problem of protection. And trust me, this is a very unique and fascinating puzzle. Now, this is the most important thing to remember about PNH. Unlike thalassemia, which you inherit from your parents, PNH is acquired. That means you are not born with it. It's caused by a genetic mutation that just happens, randomly, in a single stem cell in your bone marrow at some point during your life. So how does it work? Well, there's a mutation in a gene called PIGA. This mutation stops the cell from making something called a GPI anchor. Now, think of this anchor like the handle on a shield. Without the handle, the cell can't hold on to its protective proteins, its armor, and this leaves it completely exposed and vulnerable to attack from our own body's own defense system. And this is how we diagnose it, using a technique called flow cytometry. It's very clever. On the left, you see a normal blood sample. See how all the cells are in one group? Now look at the right. This is from a PNH patient. You can clearly see a second population of cells, shown here in red. Those are the culprits, the defenseless cells that are missing their shields. And the consequences of being defenseless are, well, they're severe. A huge number, up to 40% of patients with PNH, will develop thrombosis. That's a medical term for blood clots. And these clots are dangerous. In fact, thrombosis is the leading cause of death for people with PNH. So we've been talking about this idea of friendly fire. Let's take that concept and dive into our third and final case file for today. We're now going to look at immunohemolytic anemias, where the immune system doesn't just make a mistake, it launches a full-scale attack on its own red blood cells. Now, there are two main types here, and the key difference is temperature. It's quite interesting. In what we call warm antibody type, the destructive antibodies are most active at our normal body temperature, 37 degrees Celsius. But in cold agglutinin type, the antibodies only cause problems in colder temperatures, which is why patients often have issues in their fingers, toes, and ears. Now look closely at this blood smear. Do these look like healthy, round red blood cells? No way. They're fragmented. They're torn apart. These are called schistocytes, and they are the microscopic evidence of a brutal physical battle happening inside the patient's blood vessels. Okay, we have covered a lot of important ground today, so let's just pause for a moment and summarize the key points. These are the core concepts that you really must take away from our session today. So to boil it all down, thalassemia is fundamentally a production problem. PNH is a defense problem, a lack of shields, and immunohemolytic anemia is an autoimmune problem, a case of mistaken identity. If you can just remember those three simple ideas, you'll have a very strong foundation for understanding these disorders. And that brings us to the end. But I want to leave you with a final question to think about. When you see how our own cells can be so vulnerable to simple manufacturing defects, to accidental friendly fire, doesn't it just make you appreciate the incredible, delicate biological balance that is required to sustain our lives every single moment? It's really quite a miracle, isn't it? Okay, we'll see you in the next class.
All right, everyone, welcome. Today, we're going to dive into a topic you'll see again and again in your practice, the anemias. Now, I know it can seem a bit overwhelming, but trust me, by the end of our session, you'll be reading a blood report like a detective reads clues. Ready to solve some medical mysteries? Let's begin. So let's start with a question that's so basic we sometimes forget to even ask it. Why is our blood red? What is it that gives blood that rich, vibrant color we associate with life itself? Just take a second and think about it. The answer is really at the very heart of everything we're going to talk about today.
And the answer, as I'm sure many of you guessed, is all thanks to one superstar element, iron. Yep, it's that single iron atom sitting right in the middle of the heme molecule inside our hemoglobin that grabs onto oxygen. And that very interaction is what gives blood its signature red color. Simple enough, right? But this is where things start to get interesting.
See, here's the catch. Iron is absolutely essential, but our body has no easy active way to get rid of any excess. This means managing our iron levels is an incredibly tricky balancing act. Too little, and we can't make enough hemoglobin, but too much, and it actually becomes toxic to our organs. Chala. Let's find out how our body handles this critical job.
To really understand this balancing act, we need to meet the master regulator, the chief chowkidar, or gatekeeper of iron in our body, and its name is hepcidin. This little hormone, believe me, is the main character in our story today.
So what is hepcidin exactly? Well, technically, it's a peptide hormone that's made in the liver. And its whole job, its entire purpose, is to be the principal regulator of how much iron we absorb and where that iron goes. You can really think of it as the ultimate boss of iron metabolism.
So how does this boss actually do its job? It's really quite clever. Hepcidin doesn't touch the iron directly. Instead, it controls the main gate for iron, which is a protein called ferroportin. Now, this gate is on the surface of our gut cells where we absorb iron and on our storage cells. Hepcidin basically acts like the key to a padlock on this gate, deciding when it's open and when it's slammed shut.
And this creates a really beautiful, elegant feedback loop. It works like this. When the liver senses that we have plenty of iron, it starts releasing more hepcidin. That hepcidin then travels and locks down those ferroportin gates. This traps iron inside our gut cells and our storage cells, preventing it from getting into the bloodstream. It's a fantastic system designed to stop us from getting iron overload.
Okay, so now that we get the normal system, let's look at what happens when things go wrong. And our first case is the most common type of anemia in the entire world, the case of the missing iron, or what we call iron deficiency anemia.
So why does the iron go missing in the first place? Well, there are four main culprits. It could be a simple lack of iron in the diet, or maybe poor absorption because of some gut issue. Sometimes there's just an increased demand, like during pregnancy. But, and listen carefully, this is a huge clinical pearl. In an adult man or a postmenopausal woman, the #1 cause you must always think of is chronic blood loss.
You have to suspect a GI bleed until you've proven otherwise. And this is what the blood actually looks like under a microscope when it's being starved of iron. The red blood cells are visibly smaller than normal, which we call microcytic, and they have this large pale area in the center, which we call hypochromic. They look like sad, empty little rings because there's just not enough hemoglobin to fill them up. Small and pale, that's the classic signature.
The lab tests tell the exact same story. Serum iron is low, obviously. Ferritin, which is our marker for iron stores, is also really low. The storage tanks are basically empty. So what does the body do? It panics. It increases something called the TIBC, the total iron binding capacity. It's essentially sending out more transport proteins to desperately search for any scrap of iron it can find. And crucially, hepcidin is low. The gatekeeper has thrown all the gates wide open, trying to absorb every last atom of iron possible.
Okay, let's move on to our next case, which is a bit more of a puzzle. I like to call it iron in lockdown. The proper name is anemia of chronic inflammation. And in this situation, the strange thing is, the body has plenty of iron, but it can't use it. Let's see why.
I want you to think about it this way. In conditions like chronic infections or autoimmune diseases or even some cancers, the body is in this constant state of high alert, of inflammation. It thinks it's under attack. And because many invading bacteria need iron to survive and grow, the body makes a very clever strategic decision: hide the iron from the enemy.
So how does the body hide the iron? Well, those inflammatory signals, especially a cytokine called IL-6, they send a false message to the liver. They basically trick the liver into pumping out massive amounts of hepcidin. And we know what high hepcidin does, right? It goes and locks down all the ferroportin gates, trapping all the iron inside our storage cells.
And this brings us to the single most important diagnostic clue you need to know. In iron deficiency anemia, the stores are empty, so the ferritin level is low. But in anemia of chronic inflammation, the stores are full, they're just locked up. So the ferritin level will be normal or even high. This is the key difference. If you remember this one thing, you will avoid so much confusion in your clinical practice.
Okay, so far we've talked about problems with the raw materials, specifically iron. But what if the problem isn't the materials at all? What if the problem is with the factory itself? Our final case for today looks at exactly that, a situation where the entire blood cell factory, our bone marrow, simply fails. This is aplastic anemia.
So just let that sink in for a moment. What if the problem isn't a lack of iron or vitamins or any building blocks? What if the bone marrow, the very place where all of our blood cells are born, just shuts down, stops working completely? Well, that catastrophic failure has a name. It's called aplastic anemia. It's a syndrome of complete bone marrow failure. And because the entire factory is out of commission, you get a shortage of everything it makes. Not enough red cells, which causes anemia, not enough white cells, which leads to infections, and not enough platelets, which leads to bleeding. This shortage of all three cell lines has a specific name: pancytopenia.
And this image is so dramatic, it tells the whole story. On the left, you're looking at a biopsy of a healthy, busy bone marrow packed with all the cells that make blood. Now look at the right. That's aplastic anemia. The factory is empty. It's been almost completely replaced by fat. We call this a hypocellular marrow. There's just nothing there to make new blood.
So what on earth could cause such a devastating shutdown? Well, the list of culprits includes certain chemicals and drugs, some viral infections, and high doses of radiation. Sometimes it's actually the body's own immune system attacking the stem cells. But what's really humbling for us as doctors is that in about 2/3 of all cases, we simply don't know the cause. We call those cases idiopathic.
All right, that was a lot to take in, I know. So let's just take a moment to put it all together with a quick summary. This should help you decode these different anemias when you see them on the wards.
So here's your quick cheat sheet. For iron deficiency, the problem is not enough hemoglobin, and the key feature is low ferritin. For anemia of chronic inflammation, the problem is trapped iron, and the key feature is high ferritin. And for aplastic anemia, the problem is total factory failure, and the key features are a hypocellular marrow and pancytopenia.
And so, we end right back where we started. Every single blood count you order tells a story. It's a story of raw materials, of factories, and of gatekeepers. The question I want to leave you with is this: now that you're learning the language of the blood, what clues will you look for? Thank you. Good morning, my dear students. Welcome, welcome. Cholo, let's get started. Today we're going to dive into a topic that is, well, it's absolutely critical for your clinical years. We're talking about bleeding disorders. We'll explore what happens when the body's amazing system for stopping bleeds just goes wrong. So, let's begin.
So what's on the menu for today? Here's our little roadmap. First, we'll talk about what happens when the glue holding our platelets together fails. Simple enough, right? Then, we'll look at the domino effect of the clotting cascade and what happens when one of those dominoes is missing. After that, we tackle the real drama, the paradox of DIC, where there's clotting and bleeding all at once. We'll also quickly touch on the risks of treatment, and of course, I'll wrap it all up with a high-yield recap, just for your exams.
All right, first on our list is von Willebrand disease. I want you to imagine this thing called von Willebrand factor, or VWF, as a kind of molecular superglue. Its job is to help platelets stick to a damaged blood vessel wall. But what happens if that glue is weak, or if you just don't have enough of it? Let's find out.
Okay, a quick question for all of you brilliant minds to get the brain cells working. Based on your reading, which inherited bleeding disorder are you most likely to see in your future practice? Any ideas? Think about it. What's the most common one?
That's right, it's von Willebrand disease. And look at that number. It affects about 1% of the population. 1%. All right, that might not sound like a lot, but in a country of our size, that means you will definitely see these patients. Often, it's quite mild, and a person might not even know they have it until some surgery or even a dental extraction suddenly reveals that they bleed too much.
So, what are the clues? What should you be looking for in your clinic? Well, the classic signs are these nosebleeds, epistaxis, that just seem to happen for no reason at all, or cuts and scrapes that just bleed on and on for a very long time. And in your female patients, you must be very alert for a history of heavy menstrual periods, or menorrhagia.
Now, this table, listen carefully, this is a 5-star question for your exams, okay? Pay close attention to the defect type column. You see, type 1 and type 3 are quantitative problems. That means there's simply not enough of the VWF glue. But type 2, that's a qualitative problem. The glue is there, but it's faulty. It doesn't work properly. Understanding this difference, quantitative versus qualitative, is absolutely key.
Okay, so let's move on. We're going from a problem with glue to a problem with dominoes. You see, the coagulation cascade is this beautiful, precise sequence of events, just like a line of dominoes falling one after the other. Hemophilia is what happens when one of those dominoes is just missing, and the whole chain reaction just stops.
You need to know 2 main types. Hemophilia A, which is a lack of factor VIII, and hemophilia B, a lack of factor IX. Both are X-linked recessive, so you'll see them almost exclusively in male patients. But, and this is the most important part to remember, despite being different diseases at the molecular level, at the bedside, they look exactly the same. You cannot tell them apart just by looking at the patient.
So, what does a hemophilia patient look like? Well, you'll see massive bleeding after an injury, of course, but also spontaneous bleeding. And a real hallmark of hemophilia is bleeding into the joints, hemarthrosis, which is incredibly painful and can cause permanent damage. And now for a key diagnostic clue. Please remember this. Petechiae, those tiny little pinpoint bleeds you see with platelet problems, are absent here. This is a vital point for differentiation. Write it down.
All right, our third topic is, well, it's the most dramatic, the most chaotic condition of them all, disseminated intravascular coagulation, or DIC. This is a true medical emergency, a paradox of chaos where the body is both clotting like crazy and bleeding uncontrollably, all at the same time.
The definition itself gives you the whole story. Thrombo-hemorrhagic. Thrombo for clotting, hemorrhagic for bleeding. So how can this be? How can you be clotting and bleeding at the same time? It's a paradox, no? Just imagine the body's clotting system goes completely haywire. It starts forming tiny clots everywhere, and in doing so, it uses up all the platelets, all the clotting factors. It consumes everything. And then, when a real bleed happens, there's nothing left in the tank to stop.
Look at this slide. It shows the devastating chain reaction. And please remember, DIC is never a primary disease. It's always a complication of something else. Some severe trigger kicks off this widespread clotting, which damages tissues. This then consumes all the body's clotting resources, and that leads to uncontrolled bleeding. It's a true domino effect of the worst possible kind.
So what can push the body into this chaos? Sepsis is a huge one. Massive trauma, some cancers, and certain complications of pregnancy are also common triggers.
So if you have a patient with one of these conditions and they suddenly start bleeding or oozing from their IV sites, your mind must immediately scream DIC. You have to have a very high index of suspicion.
Okay, very quickly, let's talk about treatment. For many of these bleeding disorders, the life-saving thing to do is give a blood transfusion. But this treatment, is not without its own set of risks. We have to be aware of transfusion reactions.
This slide gives you the whole spectrum. On the mild end, you have things like simple febrile reactions, which are the most common. But on the severe end, you have truly life-threatening conditions like acute hemolytic reactions. That's what happens if you give the wrong blood type. And TRALI, which is a severe form of lung injury. This is why, as junior doctors, your job is to be so careful when a patient is getting blood.
All right, Chalo, let's bring it all home now. It's time for the most important part for many of you, the professor's high-yield recap. These are the absolute must-know points for your exams and for your life on the wards.
So, let's lock this in. Von Willebrand disease, problem with the platelet glue, the most common one you'll see. Hemophilia, a missing domino in the cascade. Classic presentation is bleeding into joints. And DIC, the great paradox of clotting and bleeding, and it's always secondary to something else. Got it? Glue, dominoes, and chaos.
And I will leave you with this final thought. This isn't just about theory or passing your exams. This is about building a crucial clinical skill, recognizing these patterns of bleeding at the bedside. So I want you to ask yourselves, when you're on call at 2 a.m. and you have a patient who is bleeding, how will you use what you've learned today to figure out what's going on and save that person's life? Think about that. Thank you.